Bismillahirrahmanirrahim. I'm going to present the RCOG guideline of sickle cell disease in a pregnancy in somewhat different way. Okay, I have presented different videos about the RCOG guideline in which I have used the PowerPoint and different other methods, but in this video I would like to make use of my own drawing so that understanding becomes so easy for you, and this topic becomes a little bit interesting for you and become easy to understand. So this is RCOG guideline about the sickle cell disease. Okay, in every guideline we have purpose and scope, background and introduction. In the background and introduction, that definition is written. Okay, and that's what I'm trying to explain it to you. I'm drawing the gene of the I'm trying to show you the genetic material of the hemoglobin structure basically. So what happens that there is sickle cell gene inside the hemoglobin structure that results in the sickle cell disease. Okay, sickle cell disease is basically a group of inherited single gene autosomal recessive disorder which is caused by sickle cell gene. Okay, this is the sickle cell gene, and that results in affecting the basic structure of the hemoglobin. When the structure of the hemoglobin is affected, then the shape of the hemoglobin is changed from normal biconcave shape to that of the sickle cell shape. Okay, sickle cell shape of the hemoglobin of the red blood cell has tendency to break down, and that results in hemolysis and anemia. Now coming to the variants of the sickle cell disease, these things are written in the RCOG guideline. We have the different variants. Okay, one is that of the hemoglobin as C, other is hemoglobin as B. Okay, other is hemoglobin D. Then we may have hemoglobin O Arab. Okay, hemoglobin E is also there, and all of these genotypes will have similar clinical phenotype of varying severity. Okay, we have other types like hemoglobin AS. Okay, and patient is usually asymptomatic except for the possible increased risk of urinary tract infection and microscopic hematuria in these asymptomatic types. Okay, these are all the variants which are basically included among the minor category of the sickle cell disease. Among the major category of the sickle cell disease, we have HBSS, which causes increased level of hemolysis. Now coming to the incidence. Okay, it is said that basically this sickle cell disease is common among the sub-Saharan Africa and Middle Eastern population. Okay, hence it is most prevalent in the individual of the Africa descent as well as Caribbean, Middle East and part of the India and Mediterranean and the South and Central America. Okay, now I'm drawing the picture of the Africa. Okay, and then east to the Africa we have the Europe, and apart from that we may have the other parts like the Asia, Pakistan and India are there. Okay, and on the other part of the world we have America. Okay, so it is said that South and Central America are the areas which are at increased risk of the people of which are increased risk of the sickle cell disease. Okay, and it is said that there are 3 lakhs children with sickle cell disease each year, and 2/3 of the patients with the sickle cell disease, of the babies with sickle cell disease, are born in Africa. So 2/3 Africa, you should remember this thing. As far as UK is concerned, in UK it is said that there are 12,000 to 15,000 affected individuals and over 300 infants born with sickle cell disease in UK each year, who are diagnosed as part of the neonatal screening program. Okay, and how many pregnancies? 100 to 200 pregnancies are affected by this. Now coming to the pathophysiology, as we have shown, as we have told you that there is sickling of the cell as a result of changing the structure of the hemoglobin. So that sickling of the cells of the hemoglobin causes polymerization of this abnormal hemoglobin in the presence of decreased oxygen. So we have decreased oxygen that results in polymerization of the hemoglobin. Okay, polymerization of the hemoglobin causes rigid and fragile sickle cell shape red cells, and these cells are basically prone to increased breakdown, and that causes hemolytic anemia and to vaso-occlusion of the vessels, especially the small vessels. Okay, and we have certain complications as a result of this pathophysiology. Okay, the first main complication is that of the anemia, hemolytic anemia, as a result of that pathophysiology. Okay, so if under microscope we check the red blood cell count, these are decreased. Okay, and it also causes acute painful crisis. Other features of acute painful crisis are also there. And what are the complications at different organs level? First of all, stroke. We have to keep in mind the stroke as a complication. Okay, now this sickle cell disease also causes pulmonary hypertension because it affects the vessels of the lungs as well. Okay, along with the stroke and pulmonary hypertension, we should keep kidney in our mind because it results in renal dysfunction because of the same pathophysiology which I have explained to you. Okay, and apart from the kidney, keep in your mind the liver and the gallbladder structure as well. Okay, there is increased tendency to form the stones in the gallbladder. The condition is called cholelithiasis, as all of you know. So cholelithiasis is also one of the most important complications of the sickle cell disease. Okay, so I'm drawing the picture of gallbladder. Inside the gallbladder, if we have stones, that is called the cholelithiasis. Okay, that is one of the important complications of sickle cell disease. Okay, so hemolytic anemia, stroke, pulmonary hypertension, renal disease, cholelithiasis. Okay, now I'm drawing the picture of the eye so that you don't forget the retinal disease. Okay, retinal diseases are also the result of sickle cell disease in pregnancy. Okay, the sickle cell disease also affect the retina. Now I'm drawing the picture of the femur. Okay, in the femoral head, there is a vascular necrosis. Down the femur, we have legs. Okay, and in the legs, what does it cause? It causes the leg ulcer. So, a vascular necrosis of the head of the femur and the leg ulcer. These are the other complications of the sickle cell disease. Okay, so by looking at this picture, it would be easy for you to memorize the possible complications as a result of sickle cell disease. Now coming to the other point 4 in the RCOG guideline, and that is about the preconception care. Okay, patient has not conceived yet. How would we take care of her? What care can we provide to her? Okay, so the first question that we have to keep in our mind regarding the preconception care is that what are the additional risks to the woman and the baby? Okay, women risk not only to the baby but also to the mother are important. Both are very important parts of the preconception care. We have to counsel the woman, we have to tell the mother that her fetus is at increased risk of possible complications like increased incidence of perinatal mortality, okay, premature labor, the fetal growth restriction. Okay, these are the possible complications in the fetus. Mother may suffer from acute painful crisis during pregnancy. Okay, And in early pregnancy, she's at increased risk of the spontaneous miscarriages. Okay, and increased antenatal hospital admissions. Okay, I have drawn the picture of the baby. Now I'm drawing the picture of the mother's arm so that the blood pressure is in your mind. It is related to sickle cell disease complication because sickle cell disease can result in pregnancy-induced hypertension or preeclampsia. Baby may suffer from preterm labor, as I have told you. Okay, baby may suffer from decreased growth or fetal growth restrictions. Okay, so we have to tell the mother about all these things. Also, there is increased risk of cesarean section as shown in the figure and increased risk of postpartum complications as well. Okay, and there is increased risk of antepartum hospital admission. Okay, the patient of sickle cell disease, when she gets pregnant, she would have repeated admissions to the hospital. So we have to tell the patient about all these things in the preconception care. So basically the counseling is important. Second thing is that what is the importance of planning pregnancy and how can the outcome of the woman and the baby be improved. So planning 4.2 is about the planning of the pregnancy. Okay, about this it's written that from adolescence, the intention of the woman with sickle cell disease regarding pregnancy and contraception should be documented at each contact with the sickle cell care team. Okay, and we have to tell the woman that how this pregnancy affects sickle cell disease and how sickle cell disease affects pregnancy. Okay, so these arrows shows that both affect each other. Okay, and the role of the primary care physician is very important. I'm drawing the picture of the primary care physician. Primary care physician have a role in the preconceptual screening, including the provision of the contraceptive advice. Okay, and women with sickle cell disease should receive not only general preconceptual care, which is given to all women, but also additional advice about the vaccination, medication, and crisis avoidance. Okay, so and also we have to give advice to have low threshold for seeking medical help because the sickle cell disease is a bit complicated problem for the general population. So she should seek advice. She should have a low threshold for seeking medical help. Now coming to the 4.3. What is the importance of the genetic screening? The genetic screening is explained in 4.3 and what procedures are involved. Okay. About this, it's written that women and men with a sickle cell disease should be encouraged to have hemoglobinopathy status of their partner determined before they embark on pregnancy. If identified as an at high risk couples as per National Screening Committee, they should receive counseling and advice about the reproductive options. Okay, so this figure basically represents the genetic screening program. Okay, we have mother, we have father. For both we check the genes, the genetic makeup is checked for both mother and the baby, mother and the father in order to assess the genetic makeup of the baby. That is important. Okay, now coming to the point 4.4. What is the importance of antibiotic prophylaxis and immunization? About this, it's written that penicillin prophylaxis or equivalent should be prescribed. Okay, and vaccination status should be determined and updated before pregnancy. Okay, I'm drawing the picture of antibiotics. Okay, it's very important that we prescribe the specific antibiotics, especially the penicillin antibiotics. Patients with sickle cell disease are hyposplenic and are at increased risk of infection. That is the basic reason why we need antibiotic prophylaxis, because they are hypersplenic. They are at increased risk of infection, in particular from the encapsulated bacteria such as Neisseria meningitidis and Streptococcus pneumoniae and Haemophilus influenzae. Okay, and apart from that, there is a role of vaccination as well. Okay, and vaccination should be given Haemophilus influenzae type B and the conjugated meningococcal C vaccine as single dose if they have not received it as a part of primary vaccination. The pneumococcal vaccine, Pneumovax, okay, should be given every 5 years. Okay, antibiotic prophylaxis, penicillin, and Pneumovax, the pneumococcal vaccine, every 5 years. And hepatitis B vaccination is also recommended for the woman. Woman immune status should be determined preconception. Now coming to the point 4.5. What vitamin supplements should be given? About this, it's written that the most important among all is that of the folic acid, but not the usual dose. We have to give a little bit higher dose as compared to the normal pregnant woman. We have to give 5 milligram folic acid that should be given once daily, both preconceptually and throughout the pregnancy. Okay, because for the first 3 months she should receive this folic acid. Okay, folic acid is recommended in all women to prevent neural tube defect. Okay, now coming to the point 4.6, medication review. What medication should be reviewed preconceptually? Okay, we cannot prescribe each and every medication. We should check what medication is our patient taking. Okay, so the certain medication should be stopped, certain medication should be reviewed. First of all, hydroxycarbamide or hydroxyurea, that should be stopped at least 3 months before conception. Hydroxycarbamide has been demonstrated to decrease the incidence of acute painful crisis and ACS in individuals with a severe clinical manifestation of sickle cell disease. Okay, hydroxycarbamide is in fact teratogenic. Okay, and also there are side effects of ACE inhibitor and angiotensin receptor blocker. So we should avoid these medication preconceptually. Now coming to the point 5, which is basically about the antenatal care. Okay, now patient has become pregnant. She has come out of the preconceptional stage. Now she is in her antenatal phase. So what we have to do? General aspect needs to be discussed. First of all, this woman should be treated in a different way. She is at high risk and she should be seen by multidisciplinary team. Okay, MDT should be kept in our mind that antenatal care should be provided by multidisciplinary team, including obstetrician. I'm making the drawing of obstetrician. She's a lady with a who is holding the baby. This is obstetrician. Okay, so obstetrician play a very important role in the care of women. Secondly, midwife. Midwife should take care. Okay, midwife with experience of the high risk antenatal care, and hematologist with an interest in sickle cell disease. These all should be there. So what is included in the antenatal care? We have a multidisciplinary team of obstetrician, midwives, and hematologists. Now, it is very important to know about the precipitating factors of sickle cell crisis. We should avoid the precipitating factors. we should tell the woman that she should avoid the precipitating factor such as exposure to extreme temperature. I'm drawing the thermometer so that extreme temperature is in your mind. Okay, she should avoid precipitating factors like extreme of temperature. Secondly, dehydration should be avoided. Okay, we have to tell the woman that she needs to keep herself hydrated and to make sure that she doesn't become dehydrated. Okay, because that can precipitate the sickle cell crisis. Along with the dehydration, the over excretion is also avoided. Okay, if she is on any diuretic, that should be stopped. Okay, and if there is problem of over excretion, then she should increase her fluid intake. Okay, and there is a common problem, especially in the first trimester of pregnancy, which is hyperemesis gravidarum or persistent vomiting. That should be avoided. Okay, and she should seek medical advice early, as soon as possible, because persistent vomiting can lead to dehydration and sickle cell crisis. That is a very important precipitating factor. So if the woman with the sickle cell disease comes with a complaint of hyperemesis, we shouldn't take it lightly. Okay, and apart from that, there is a role of influenza vaccine as well. Influenza vaccine should be recommended if it has not been administered in the previous year. Okay, so every year it should be repeated. Now coming to the point 5.2 in RCOG guideline, which is about antenatal hemoglobinopathy screening. Okay, about this it's written that if the woman has not been seen preconceptually, okay, there are some certain groups of women who don't give much attention to them, who don't bother about their health. So in the preconception phase, she has not come to seek advice or to discuss each and everything with you, preconception care has not been provided to her, then she should be offered partner testing. If partner is a carrier, appropriate counseling should be offered as early as possible in the pregnancy, ideally by the 10th week of gestation. I have drawn 10 weeks of gestation. Okay, so partner counseling should be provided ideally at 10 weeks of gestation, to allow the option of first trimester diagnosis and termination if that is the woman's choice. Okay, so that screening would help us not only in the first trimester diagnosis but also in the termination if that is the woman's choice. That depends upon the woman's own choice. Okay, now coming to the point 5.3, medications to be given to the woman. Very important to know. Okay, it's very important to be known by every doctor that what medication should be given during pregnancy. Okay, about this it's written that if woman has not undergone a preconception review, they should be advised to take daily folic acid and prophylactic antibiotic. Okay, and drugs that are unsafe in pregnancy should be stopped immediately. Okay, so I'm drawing the sign of danger, means those drugs which are teratogenic. Okay, all the teratogenic drugs should be avoided, as I have explained to you, the hydroxycarbamide AC inhibitors. If women is on these things, these should be avoided. Okay, and about the iron supplements, it's written that I'm drawing the shape of the certain iron supplement. Okay, iron supplements should be given only if there is laboratory evidence of the iron deficiency. Not in each and every case of sickle cell disease we have to give iron, because in sickle cell disease the problem is not that of the iron deficiency, and if we repeatedly give iron, that can cause the iron overload. Okay, so iron only if there is iron deficiency. And important thing which we need to keep in mind is that of the folic acid. Folic acid should be given 5 milligram folic acid. And antibiotic, yes, antibiotics should be given. Okay, because we need to avoid the risk of infection in such women. Prophylactic antibiotics should be given. Okay, if not contraindicated, we should check whether this antibiotic is contraindicated or not. Another very important thing in the patient with sickle cell disease is the importance of aspirin or Loprin in the dose of 75 milligrams should be given. Okay, folic acid should be given, antibiotic should be given, aspirin should be given. Okay, and another thing is about the role of the low molecular weight heparin. I'm drawing the injection, and in order to show you the role of low molecular weight heparin. Women with the sickle cell disease should be advised to receive prophylactic low molecular weight heparin during the antenatal hospital admission. Okay, low molecular weight heparin has a very important role. Okay, she is admitted in the hospital, and during admission it is very important to give her low molecular weight heparin. If she goes home, she is mobilized, so it is not important to give at that phase. Okay, now another important thing is that when we have to give aspirin, it is important to know that aspirin should be started from 12 weeks of gestation unless the patient has got aspirin sensitivity. Now coming to the point of 5.4, what additional care should be provided during the antenatal appointment? Additional care. Antenatal appointment for women with the sickle cell disease should provide routine antenatal care as well as the care specifically for the woman with sickle cell disease. These both things should be covered in the antenatal appointment. Along with usual care, blood pressure and urine analysis should be performed at each consultation, and menstrual urine for the culture performed monthly. Okay, now another thing is that what is the recommended schedule for ultrasound scanning during pregnancy? Women should be offered viability scan at 7 to 9 weeks, and women should be offered routine first trimester scan 11 to 14 weeks, and then anomaly scan at 20 weeks, and then serial fetal biometry every 4 weeks from 24 weeks onward. Now coming to the point 5.6. What is the role of blood transfusion during pregnancy? The blood transfusion role has to be discussed. We should know that what role does the blood transfusion takes place in pregnancy. About this, it's written that routine prophylaxis is not recommended during pregnancy for women with the sickle cell disease. Okay, so if someone asks that do we need to prescribe routine prophylaxis, about this written that early studies recommend prophylactic transfusion during pregnancy as there was decreased maternal morbidity and perinatal mortality among the transfused women compared with the historical control. So we don't prescribe the routine transfusion. But in case of exchange transfusion, if exchange transfusion is required for the treatment of sickle cell complication, it may be appropriate to continue the transfusion regime for the remainder of the pregnancy. Okay, if exchange transfusion is required, then continue transfusion. Another thing is that blood testing should be done. Okay, blood should be cross-matched for extended phenotype, including full rhesus typing, CDE, as well as cal typing. Okay, so we have to do the testing, the proper cross-matching, proper testing for including the full rhesus typing, CDE, as well as the cal typing. And blood for transfusion in the pregnancy should be CMV negative as well. I will make the drawing later on. First of all, let me explain to you the rhesus typing, CDE, and cal type. CMV, we have to keep in our mind, the CMV should not be present in the blood. Blood should be CMV negative. That is a very important protocol which needs to be followed. Now coming to the 5.7, what is optimal management of acute painful crisis during pregnancy? Sometimes patient may suffer from acute painful crisis. How to deal them? Women with sickle cell disease who become unwell should have sickle cell crisis excluded as a matter of urgency. Okay, woman is unwell, we should exclude the sickle cell crisis. This thing should click our mind whether she has got acute sickle cell crisis or not, because that is a matter of urgency. That is an emergency situation. We have to deal it in a proper way, because the painful crisis is most common complication of sickle cell disease during pregnancy. Okay, that must be excluded. Secondly, pregnant women presenting with acute painful crisis should be rapidly assessed by multidisciplinary team. Again, the role of the multidisciplinary team comes. An appropriate analgesia should be administered. Okay, the role of multidisciplinary team is very important, and that includes a team of obstetrician, midwife, anesthetist. Okay, and they should prescribe the appropriate analgesia to avoid the risk of seizure. Okay, multidisciplinary team includes obstetrician, secondly midwives, third is hematologist, and fourth anesthetist, hematologist. Okay, obstetrician, midwife, anesthetist, and hematologist. These things should be kept in mind. These people should be kept in mind. Now, pethidine. Should we give pethidine? No. Pethidine is contraindicated. It shouldn't be given because of associated risk of seizures. Okay, if we draw the diagram of the brain, so it will be clear along with the pethidine that it is associated with increased risk of seizures. Okay, and another thing is that the requirement for the fluid and oxygen should be assessed and fluid and oxygen administered if required. IV fluid should be given and oxygen should be given to these patients. Okay, we give proper IV fluids to these patients in order to give her relief from acute painful crisis. And another thing is that we have to give proper oxygen. Okay, we have to maintain the oxygen saturation to a proper target level. Okay, along with that, it's very important to draw thromboprophylaxis diagram as well, as I will draw that as well. Okay, oxygen should be given, IV fluid should be given. I'm drawing that basically. Okay, thromboprophylaxis. The role of thromboprophylaxis should not be forgotten. Now coming to the point 5.8. What are other acute complications of sickle cell disease and how are they treated? Acute complications are to be discussed. About this is written that all the patients, carer, medical, nursing staff should be aware of other complications of sickle cell disease, including, first of all, the most important is ACS. I'm drawing the picture of the heart in order to make you remember that ACS is one of the important complication of the sickle cell disease. Okay, first is ACS, acute coronary syndrome. Okay, and it occurs in 7 to 20% of the pregnancy. Second is that of the acute stroke. Acute stroke, a very important complication of the sickle cell disease. Usually the cause of stroke is unknown in most of the patient, but if she is known patient sickle cell disease, then that might be the cause. And third important complication is that of the anemia. Okay, so basically we have ACS, stroke, and anemia, three main complications. Okay, all patients should know, carers should know, medical staff should know. And I'm drawing the picture of hospital. Why? Because There should be certain arrangement in each and every hospital for managing complications. If they have labeled their building as hospital, then there must be arrangement for the management of acute coronary syndrome. Okay, uh, and there should be arrangement for transference therapy as well. Each hospital should have a protocol in place for the management of ACS in pregnancy, including the use of transfusion therapy. Okay, because they need special protocol, they need special care. Now come to the intrapartum care. Patient has come out of the antenatal phase. Now it's the time to deliver her. Okay, about this, it's very important to know that what is the optimal timing and mode of the delivery. Okay, the baby is in the womb, the baby is in the uterus of the patient. She's asking from you that when will my baby be delivered? When are you intended to deliver my baby? Tell me the time. Secondly, tell me the mode. Will it be normal delivery or it should be cesarean section? About this, it's written that women with sickle cell disease who have normally grown fetus should be offered elective births through induction of the labor or C-section after 38 plus weeks of gestation when the baby is quite mature. And another thing regarding the delivery we should keep in mind is that sickle cell disease is not a contraindication of vaginal birth. Okay, and it is not a contraindication of IUL. It is not a contraindication of vaginal birth after cesarean, mean it is not contraindication of the VBAC. Regarding the intrapartum care, it's very important to know that the blood should be cross-matched for delivery if there are atypical antibodies present, since this may delay the availability of the blood. Otherwise, group and save will suffice. In a woman who have hip replacement, because of the avascular necrosis, it is important to discuss the suitable position for delivery as well. Okay? Because there are certain women who had the complications of avascular necrosis in the past, or they had hip replacement in the past. It is important to know, or it is important to discuss the position of the delivery with her. If that proper positioning is not suitable or not acceptable to the woman, we can offer her the choice of cesarean section. Okay. And it is also written in the guideline that cesarean section is to be considered based upon the obstetric indications. Means not in every case of the sickle cell disease they should offer cesarean section. Women with a hip replacement who had avascular necrosis might be difficult to have normal delivery, so cesarean section can be offered. Now coming to the point 6.2, what is the optimal care and place of the birth for women with sickle cell disease? Women with a sickle cell disease should be advised to give birth in a hospital. I'm drawing the picture of the hospital, and that hospital shouldn't be usual hospital. That should be fully equipped. Okay, there should be an ability in that hospital that the complications are managed. Okay, and high-risk pregnancies are dealt with success. Okay. Women with sickle cell disease should be advised to give birth in a hospital that are able to manage both complications of sickle cell disease and high-risk pregnancies. Again, the role of the multidisciplinary team comes. The relevant multidisciplinary team, the team of senior midwife in charge, senior obstetrician, anesthetist, and hematologist should be informed as soon as the labor is confirmed. The labor is confirmed, MDT should be involved. Another thing is that women should be kept warm. I'm making the shape of blanket in order to explain it to you. Women should be kept warm. She should be given adequate fluid during labor. Okay. Blanket should be put on the woman and proper fluids should be given to the woman. Okay, so we have to give specific consideration to these women as these are the high-risk women. Now regarding the baby, definitely as compared to the low-risk woman, we have to provide the continuous intrapartum electronic fetal heart rate monitoring owing to increased risk of fetal distress which may necessitate operative delivery. Continuous electronic fetal heart rate monitoring is recommended in these women. Okay. There is increased risk of fetal distress. That is also written in the guideline that during labor, if hydration is not tolerated or inadequate, intravenous fluid should be administered using fluid balance chart to prevent the fluid overload. Fluid balance chart should be used. Okay, there's increased demand of oxygen, hypoxia chances are there, fetal distress chances are there. Now, point 6.3, what is the optimal mode of analgesia and anesthesia? Okay, definitely these women require analgesia. So, what consideration should be given? Women with the sickle cell disease should be offered anesthetic assessment in the 3rd trimester of the pregnancy. Okay, she has passed her 1st trimester, 2nd trimester. Now she is in her 3rd trimester. We should keep in our mind in the 3rd trimester that she should be offered anesthetic assessment. In the MDT, we have included anesthetist as well. So we should refer her to anesthetist. Okay. Another thing is that avoid the use of pethidine, but other opiates can be used. Okay. Anesthetist should keep in mind, obstetrician should keep in mind that pethidine should not be given. We can give other opiates. Okay. Now, which analgesia is preferred? The analgesia of choice in her case would be regional analgesia. Okay, indication for epidural analgesia depends upon the level of the pain experienced by the woman, maternal choice, and the absence of contraindications. We can give her regional analgesia. Now, coming to the postpartum care. Now, the woman has delivered the baby. What postpartum care should be given? This is the beauty of NICE guideline. This is the beauty of RCOG and NICE guideline, that each and every aspect is explained. So, postpartum care, what should be the optimum care post-delivery? Okay, I'm drawing the picture of the lab test. Okay, in a pregnant woman where baby is at high risk of sickle cell disease, that is partner is a carrier or affected, early testing for the sickle cell disease should be offered. Early testing of the baby should be offered, and capillary samples should be tested to the laboratories where there are experience in the routine analysis of the sickle cell disease in a newborn sample. Okay, now I'm drawing the picture of pulse oximeter because we have to maintain oxygen saturation above 94% and adequate hydration based on the fluid balance until discharge. We have not discharged the woman, so we have to keep her oxygen saturation record. We have to keep her fluid balance record till we discharge the patient when she becomes stable. So for baby, we do early testing, and for mother, we do proper monitoring of each and everything. Okay, as she is admitted, she has delivered now, or she has cesarean section. So the role of low molecular weight should not be forgotten. Low molecular weight should be administered while in the hospital and 7 days post discharge following delivery or a period of 6 weeks following cesarean section. If she had cesarean section, then for 6 weeks, and if she had normal delivery, then 7 days post discharge we have to give her the low molecular weight heparin. Okay, and I have drawn the picture of antenatal and puerperal. It's written that the same level of the care and vigilance should be maintained in as described for antenatal care. Okay, we should tell the complications to them. We should keep in mind. Now coming to point 7.2 about contraception. What postpartum contraceptive advice should be given to these women? Okay, about this it's written that we can give progesterone containing contraception like progesterone only pill, Cerazette. I'm drawing the picture of Mirena because Mirena is levonorgestrel intrauterine system that contains progesterone. Okay, we can prescribe Mirena to her if she wants. We can prescribe her progesterone only pills. The brand name is Cerazette or Ganon. Okay, progesterone only pills can be given. And another thing is injectable form of progesterone contraception, that is Depo-Provera, as all of you know. Okay, injectable contraceptive Depo-Provera. Okay, progesterone only pill, Mirena, Depo-Provera, all these can be advised to the women. These are safe and effective in sickle cell disease. Now, the question arises, can we prescribe estrogen containing contraception? Yes, we can prescribe, but these should be used as second line agent. Okay, we have certain estrogen containing pills, as all of you know, combined oral contraceptive pills. And the studies have shown that there is a decrease in painful episodes in both group, but to a greater degree in DMPA group, depomedroxyprogesterone group. Now the last part is about the clinical governance. Each hospital should have protocol for the management of pregnant women with the sickle cell disease. Clinical governance is very important. Okay, for each and every problem in the hospital, there should be clinical governance. And the clinical governance